Okay, so good afternoon, everyone. I present this talk on behalf of Dr. Ayman Tayyib, who couldn't come. So actually, I'll try to be as brief and practical as possible, and it's not going to take 15 minutes as it was scheduled. So no disclosures. As Dr. Sulaimani said, mainly we have two types of adult spinal deformity or adult scoliosis. It's either the degenerative type that come with aging or the old idiopathic scoliosis that evolved over the course of time. So the main classification that is used is the SRS-Schwab classification. And so most importantly, as any spinal pathology, physical exam is extremely important to recognize the origin of the pain, evaluate the gait, the alignment, the balance. The neurological examination is often normal, as it may be associated to central canal stenosis and neurological claudication, and to check the general condition of the patient. The assessment, of course, needs to be done on full spine X-rays with bending films. If you have access to the EOS system, it's better to have the hips and knees. Of course, MRI is mandatory to understand what's happening inside the canal, and CT scan if it's a revision case. So when to say no for surgery? So if there is a kind of unconformity between the symptoms and the radiological findings, such a patient having an important complaint, but you don't see an important compression of the nerves, or you need to do a corrective scoliosis surgery in a very old patient with multiple comorbidities, or if there is an unconformity between the patient expectancy and the surgical possibility. So the patient wants to keep his trunk flexible, so in this case you should not have a long lumbar fusion. And so in this case, you may refer him for physical therapy or injections. So the indication for surgeries are usually central canal stenosis, so causing neurological symptoms, symptomatic imbalance, patient going forward, and association to impaired quality of life. So the curve magnitude of the scoliosis is not an indication by itself. So when to plan a short segment decompression, short fusion, and when to plan for a long fusion. So the short decompression plus or minus fusion is indicated in case of nerve root compression when the sagittal alignment is acceptable. In a young patient between the age of 40 and 60 to preserve the lumbar spine flexibility, or in an elderly patient with a lumbar canal stenosis without any kind of alignment coronally or sagittally. And so in this case, only the symptomatic and unstable levels can be treated. So this technique has to be avoided if the patient has sagittal malalignment. So this is an example, a 51 years old teacher, sport teacher with the right L4 radicular pain, left lumbar scoliosis of 30 degrees with the spondylolisthesis L4, L5 with obvious 4-5 degeneration and foraminal stenosis. So she underwent just the L4, L5 fusion, and at 3 years follow-up, the scoliosis is stable, and the patient was happy to keep her flexibility. This is a 75 years old active male who has been complaining of neurological claudication. So when you analyze his balance on the coronal and sagittal plane, he seems globally well aligned. So, but of course he has different levels of compression. So only several levels fenestration was done in his case without doing any kind of fusion. So what are the indications for the deformity correction? So when you have a confirmed curve progression in association to what was previously mentioned, the canal stenosis, if there is a symptomatic sagittal or coronal malalignment, or when a long decompression is needed, when you have 3, 4, or 5 levels that needs decompression. So in regards to the surgical planning, what should the fusion levels be? So, of course, the classical notion, cob to cob, when you have an important scoliosis, you need to look carefully on the sagittal plane, and I will come later on to that. So you need also to check the degenerative segments, mainly L4, L5, and L5S1 when you want to stop your construct distally, and to check about the canal stenosis on the MRI too. So the upper instrumented vertebra can be at different levels. It can be at the proximal lumbar level in case of lumbar degenerative curve when the thoracolumbar junction is not kyphotic. It should be at the thoracolumbar junction in case it's an idiopathic lumbar curve and the thoracolumbar is still not kyphotic. It can be at the lower or the mid-thoracic curve in case of thoracolumbar kyphosis, or in case of thoracolumbar curve. And it will need to be at the upper thoracic spine in case of double major curves or in case of global kyphosis of the thoracic spine. And in regards to the lower instrumented vertebra, this is where the MRI is important because you will need to assess the disc degeneration and the lumbar sacral curve flexibility. So for the first element, the MRI, and for the second one, the bending. The bendings are very important to assess the lumbar sacral curve. So sometimes we can stop at L4 if the lumbosacral curve is flexible, if there is a really mild degeneration and without stenosis, but usually it's advised in rather younger patients below the age of 60. L5 is really the lower level of the construct because it will be the last level, so the only disc would be L5S1 and there will be very important stress on it, so it's better when possible to avoid it. Otherwise, S1 iliac and the iliac fixation is indicated almost for all the patients after the age of 70, or when there is an important degeneration of the lumbar sacral junction. In this case, always S1 plus iliac, not only S1. A pelvic extension is mandatory. So this is a case where there is a lumbar curve and the lower discs are not degenerated. So in this case, we can do a short segment stopping at L4, which would correct the deformity and enable the patient to have good flexibility with two discs distally that are flexible. This is a case with a thoracolumbar curve. She was 42, but unfortunately the L4, L5, and L5S1 discs were degenerated. So I had to go down to the pelvis and proximally just above the deformity. This is a case actually with a lumbar curve, but with an important coronal malalignment and sagittal malalignment with, as you can see, a global kyphosis and a coronal deformity toward the right side. So in this case, we need to go to the upper thoracic spine, so T4 to the pelvis. This is my, not the last one, just before picture to show you that, of course, it's advisable now when we do an important surgery for ASD, it's advisable actually to do a multi-rod construct. So, yeah, the multi-rod construct, as you can see down, and usually I end up the construct with a claw hook construct proximally to enable a smooth transition between the fused area and the flexible area. And also, always when you are doing the sacropelvic fixation to put a cage at L5S1. This is just in order to avoid as much as possible the complications. So my take-home message, always perform the full spine X-ray for the assessment. First, decide if the surgery is really indicated. Decide if it's either a short segment or you need really a deformity correction. And so the elements for planning are disc degeneration, the sagittal profile, and the flexibility of the main curve and the lumbosacral curve. And honestly, from my own experience, I can tell you that I'm becoming less and less aggressive with aging. Thank you.